Today we are having our session on heart. It's going to be taught to us by none other than our consultant hand surgeon at Aster Medical Center, Dr. Binoy. So welcome, sir.
Okay. Thank you. So hello, am I audible?
Yes, sir, you're audible, sir.
Uh, okay. So the topic is dilemmas in scaphoid non-union. We know that scaphoid non-union is a very confusing thing because we are actually don't know what to do when you see that, whether you should wait, whether you should fix it, if you are fixing it, with what you should fix it. So the confusion is actually a lot. So yeah. So it was the first. It was described by the Adams and Leonard, who described the bone grafting. So initially, it was almost like very difficult because they don't have the surgical drills which we have. They don't have the expertise that we have. So like which made call comment in 1935 in JBJS that bone grafting or the fracking has been done with some success, but never will be a choice for routine procedure, and it is mainly a surgical stunt. I'm sorry, my keys are not working.
സാറേ ആ ടെക്സ്റ്റ് ആ PPT ക്ലിക്ക് ചെയ്തിട്ട് ബട്ടൺസ് നോക്ക് സാറേ.
Okay. Sure. Okay. Yeah. So let's divide the topic into three, like what is a scaphoid non-union, how it can be diagnosed, and how it can be treated. So just three simple steps. So many times when you open the scaphoid non-union, we actually get confused because the non-union site will be covered with the articular, with the fibrous tissue, and you really won't see the scaphoid non-union. And you may even start thinking whether you have opened the wrong side. So that's why Burton has told, even with the scaphoid in front of you, it can be difficult to decide whether it has united or not. So we should understand that the definition of non-union is not standardized. So we say non-union when there is a failure of union following cast immobilization or surgical treatment of 6 months duration. Non-union, as we know, is defined as a fracture given sufficient time, has not united and will not unite without intervention. So delayed union includes fractures showing signs of delayed union 6 or more weeks after wearing a plaster cast. And late fractures are defined as those presenting some weeks after injury. Herbert has not mentioned some week means what, like it's 3 weeks, 2 weeks. So again, there is a confusion in that. So next is how it can be diagnosed. So remember, non-union is 6 months and delayed union is more than 6 weeks. How it can be diagnosed. So we know that the mechanism of injury is most often it is a hyperextension injury. It is the most common position of injury with the axial loading. Rarely, hyperflexion also can cause a scaphoid fracture. So next comes to the diagnostic imaging. In the X-ray, we have the standard set is 5 views, that is PA, lateral, oblique, scaphoid view, and clenched pencil view. The most, if somebody is telling you to take just 2 views for the scaphoid, then you should go for the scaphoid view and pronation oblique view. So these are the 2 most useful views. If you look at the X-ray, you should understand the sensitivity of X-ray is only 70% for scaphoid fractures. That means you look at 100 X-rays thinking there's a scaphoid fracture, 30% may not be having a scaphoid fracture. We always, what we do is when the patient is having pain, we tell them, you come after 2 weeks, you come after 3 weeks, we'll repeat the X-ray. So is there any scientific, is it proved that the X-ray later will be beneficial? No. After 10 to 14 days, even on repeated good quality radiographs, a scaphoid fracture can still be missed and the additional sensitivity is low. So it doesn't make sense to repeat the X-ray after 2 or 3 weeks. Again, with the X-ray, can you comment on avian? Increased density on the preoperative radiograph has only 40% accuracy for detecting proximal fragment avian. So that means when you see the sclerosis in 100 X-rays, 60s doesn't have avian. So many cases that were classified as AVN may actually have had satisfactory vascularity of the proximal pole. Next comes the CT. CT is taken with overlapping 1 millimeter cuts along the long axis of scaphoid. It is very useful to assess the scaphoid union after surgery, and is also useful in assessing fracture displacement, bony morphological findings, gapping, sclerosis, cyst. False positive results frequently occur due to the misinterpretation of vascular foramina or other normal lines in the scaphoid. So, CT is useful for ruling out displacement, but not for diagnosing them. So, if you are suspecting a fracture, scaphoid fracture, acute fracture, CT is not the imaging modality you should ask for. MRI is the best to determine the occult scaphoid fracture. The sensitivity is 100%. But the proximal fragment viability, again, can't be commented on a normal X-ray. It needs a contrast enhanced MRI. Even with contrast enhancement, MRI might fail to detect proximal pole AVN in nearly quarter of cases. So when we take the patient for the surgery with an AVN, we should always tell them that there is a chance that it can be vascular, or it may be avascular, especially for the waist and proximal fractures. And we should be telling them both options, like both type of bone grafting. So next is how it can be treated. So treatment we can divide into 4. One is evaluation, second is classification, next is planning, and the last is execution. So evaluation, we have 9 points. First is, where is the non-union? Second, is it displaced? Third, is there a humpback deformity? 4, is there a comminution, cyst formation, or cavitation? Fifth is DC present? Was there a previous surgery? Does the proximal pole looks avascular? Is there arthritis? If so, what stage? And the last is, the scaphoid deformed or salvageable? So the first question, let's see, where is the non-union? So we can see in this X-ray, there is a distal pole. In this, you can see there is a waist. In this, you can see the proximal pole. So again, in the same X-ray, you can see whether it's displaced or not. So next is the humpback deformity. Humpback deformity, actually accurately we can tell only with a CT, not with an X-ray. Humpback deformity happens when there is a dorsal comminution and the distal part of scaphoid flexes forwards, forming a hump. Next is there a comminution, cyst formation, or cavitation? So you can see in this X-ray the cyst. So cyst formation is something which we need to look for, because when there is a cyst, we need to use more bone graft, because we will be curating the cyst as well. So is there a DC present? So we know what is a DC. What is a DC? When the lunate is facing dorsally, we call it a DC. When it's facing volarly, it is called a PC. So in a scaphoid fracture, most of the time it is the DC, because scaphoid, the lunate is like a wife, is like a husband between two wives. So the scaphoid always tend to flex, and the triquetrum always tend to extend. So the lunate is kept in balance because of these opposing forces. So when the moment there is a scaphoid fracture, the lunate will extend with the triquetrum. That's why there is a DC deformity in a scaphoid non-union or a scaphoid fractures. So the next question is, does the proximal pole looks avascular? In this X-ray, you can see that it does look avascular, but you should always remember it is very difficult to comment based on an X-ray. So last is there an arthritis? If so, what stage? And is the scaphoid deformed or salvageable? So you can see that there is a deformity of the scaphoid. It's actually deformed, and you can see there is a radius scaphoid arthritis also. So this I'll come later about the vascularity part. Next comes the classification. Classification, this is the classification for the non-union, not for the scaphoid fractures. This is the non-union classification. It was described by Gisler. So next is the planning. So what are the treatment aims? What all things we have in mind when we try to treat a scaphoid non-union? The first is the pain relief. Second is the improved functions. Third is the prevention of late onset painful post-traumatic osteoarthritis. So this is the treatment algorithm. So this is actually the thing which we need to remember. So if there is a delayed union, that is after 6 months, or even within 6 months, if the patient comes with a gap, we can actually do a percutaneous screw fixation. You don't need to open it. So if there is a waist non-union without a deformity, can actually do the iliac bone grafting. If there is a humpback non-union, we need to go for the volar approach, because to correct it, we need to put a wedge, which should be inserted from the volar side. If the proximal pole and it's viable, you can go for a dorsal approach. You can fix with a bone graft and a headless compression screw. And if it's a avascular avian, if there is an avian, you can use either vascularized or non-vascularized. So this is an important algorithm we need to remember. So because the treatment depends only on that. So this person, you can see that this person had a fracture which was fixed from outside, and the scaphoid was somehow missed, and we fixed it after 3 weeks. You can see that it went on to unite well. So the 7 questions when we have in the treatment algorithm is, will you use a bone graft or will you just fix it? If you use a bone graft, what bone graft? Will you use a vascularized? Will you use a non-vascularized? If non-vascularized, what are your options? If vascularized, what are your options? Will you open dorsally or volarly? How will you fix it? Which imaging modality to use to assess union? So we have 2 papers which have described the percutaneous screw alone. So in one study, they have given 12 patients, but if you, and they actually have given 100% union, but you should remember that it's a small study sample. There was no control group and they did not assess the time for union. The second was a little bigger. It was 33 delayed unions and non-unions. And what is noteworthy is that they have used percutaneous screw alone for fractures from 2 months to 36 months. And they found no carpal instability, scaphoid deformity, or even of proximal fragment after the procedure, and they reported 100% union. So again, no control group, retrospective study, not mentioned the time for union. So that is like they've not even mentioned how long they took the scaphoid to unite. So we need the actually larger series, more studies to comment on the percutaneous screw fixations. The next question is, if you are using a bone graft, will you use a vascularized or a non-vascularized bone graft? So we have studies which have come regarding the non-vascularized bone grafting, whether you use a distal graft or an iliac graft. But the studies have shown that this is a study which has come out from the AIMS Delhi. So they did an RCT. They found that the union rates were 87, like the same for both. So there was no difference in terms of risk moments and functional scores. And they also found that iliac crest, when you use, there is a higher donor side complication, and they felt there was no advantage to using iliac crest as a donor site to justify the greater donor site morbidities associated with its use. So again, this is another study which shows that there is no difference in outcome between distal radius and iliac crest bone grafts. So the rate of union also was almost the same with iliac crest and the distal radius. So we tend to use a vascularized bone graft when there is an avian avascular necrosis of the proximal pole. But what we should note is that when the initial studies were reporting 100% union with a vascularized bone grafting, As time went by, like you see reports which showed 100 percentage, and you even see articles which shows 12 percentage union with vascular necrosis of the with the vascularized bone grafting. And there are few unanswered questions about vascularized bone grafting, because it is very difficult to comment whether the vascularized bone graft is still vascular, in the sense you take it from the radius and you are fixing it. So it is very like a tricky procedure. You have only chance for one attempt, and if your attempt is gone, like if your multiple attempts, the vascularity, or because the bone, the vascularized bone, it's a small piece, small chunk of bone, so it actually, the multiple attempts can actually compromise the vascularity. So it is very difficult to comment whether your vascularized bone graft is still vascular or not, or has it become non-vascular. It become like a non-vascular. So given all these unanswered questions, the role of vascularized grafting for scaphoid non-union is yet to be proved. So next is, if we are using a non-vascularized, what are our options? So we have we talked about the source of graft, iliac and radius. Now we are talking about the techniques. So we have 4 techniques. One is a Matty technique. Next is a Matty-Ruse technique. Third is a green modification of Ruse technique. And next comes the Fernandez-Fisk wedge grafting. So in the Matty technique, basically only cancellous bone is used. So that is optimum for scaphoid waist non-unions without a humpback deformity and carpal collapse. Matty-Ruse and green modification have a higher percentage of cortical to cancellous bone. So this is something which we have used Matty graft. We used we just packed it with cancellous bone grafts. This Fernandez-Fisk wedge graft is actually a tricky procedure. In the if you look at the diagrams, you will like you will feel that it's very easy, but shaping the wedge is actually extremely tricky, because it can break. You may not get the correct fit. So in the so this is something which we need to be done with caution. So and the volar wedge usually requires 3 to 6 months to heal and may result in reduced wrist motion also. So, and with the avian cases, with the Fernandez-Fisk graft, the union rates are only 30%. So the technique is very exacting, challenging to simultaneously attain excellent compression, anatomic restitution of normal scaphoid anatomy, and rigid fixation. So next is, if you are using a vascularized, what are your options? So the indication is when, as even MRI, as we mentioned earlier, even MRI, contrast MRI failed to detect 25% of avians. So it is basically an intra thing that you tell if there is an avascular necrosis or not. So the indication for a vascularized bone grafting is a avian of the proximal pole. So we have a lot of choices. We have the 4 common choices. So it is best to do something which you are comfortable and you are good at. So I do the 1-2 ICSRA. I don't do the other things, though I want to try the free medial femoral condyle graft. The other 2 are little tricky. I don't feel very comfortable with it. So this is one person came with a scaphoid proximal pole. This is the vascularized graft which you take from the radius. This is how you push it into the gap, and this is this is the union you achieve. You can, on the radius close to the styloid radial margin, you can see the defect from where we have harvested the bone graft. So again, as I told before, the initial enthusiasm is not there, because maybe I personally feel it is maybe the technique which people uses, that may be the thing actually, because some people are maybe, they just get unlucky with the graft, or they get unlucky with the fixations. But if you if you actually harvest a good graft, vascular graft, and if you get it in one shot, then I personally feel the union rates are better. So you can see that, as I showed earlier, there are a lot of articles which shows like totally different union rates from 12% to 100%. So there are articles which strongly support even now. So this paper by Henry, he had 15 patients with scaphoid non-union and proximal polyavian with humpback deformity. They have achieved 100% union with a 1-2 ICSRA. So these are all, as I said, described by different persons. This Dr. Mathulan is actually a pioneer in risk scopy also. He does the scaphoid non-union fixation scopically. Next comes the free vascularized bone grafts, that is the iliacus bone graft and medial femoral condyle graft. So these are again like these are all choices which we have. So these are the articles which support, like they give a good results. So next is, will you open dorsally or volarly? That is a major confusion people have. So you should understand that dorsal you use for proximal pole fractures. Volar you can go for distal waist or tuberosity fractures. So for a waist fracture, it's up to the surgeon. If he is comfortable with dorsals, you can do dorsal. If you are comfortable with volar, you can do volar, because orientation, everything is entirely different from in the dorsal approach and volar approach. So dorsal you use for proximal pole, volar you use for distal waist or tuberosity fractures, and the waist fractures we manage with the dorsal or volar. So the overall union rates with the volar is a little bit higher. That may be because the most of the proximal pole fractures we approach dorsally. So obviously the proximal pole fractures have less union rates than the waist fractures. So that may be one reason that which confound these figures. Next is, how will you fix it? So we have K-wires, we have compression screw, and we have staples. So the size of proximal fragment determines the type of fixation, basically. So if it's a large fragment, you can use a compression screw. If it's a small fragment, K-wire is better. So, so there are studies which compare the effect of like the success rate with a compression screw and K-wires, and they found that they actually, this was a systematic review. They found that in the K-wire analysis, there was a higher proportion of groups containing patients with fracture characteristic associated poorer prognostic fractures, such as avian and proximal pole fractures, compared with the groups which fix with the screw. So basically what they're telling is that you can't compare it, because people tend to use K-wires more when there is an avian. So, and people tend to use screws when they feel that it is a vascular, it is a fracture which doesn't have any vascular compromise. And there are thoughts that people thinking that the screw actually can compromise, disrupt the internal vascularity of bone graft more than K-wires, and hence reduces the potential benefits of vascular graft. So when people uses vascular graft, most of the people uses the K-wire, not a screw. So the next is, which imaging modality we can use to assess the union. So there was actually no statistical significant difference between the incidence of union in series where plain radiographs were used alone or where CT was used. I'm sure you all got confused. Like, I started trying to get to a solution, but I think it's again confusing. So I give you the take-home message. The scaphoid non-union is 6 months. Delayed union is more than 6 weeks. Take at least 5 views of the wrist. X-ray can diagnose only 70% of acute scaphoid fractures. If in doubt, do MRI, not CT. And difficult to comment on proximal pole vascularity till you see it yourself. And remember the treatment algorithm. So this is the treatment algorithm. And approach, tuberosity is volar. Base can be dorsal or volar. Proximal pole is dorsal. Proximal fragment, if it is vascular, we can use a non-vascularized iliac or radius graft. If it is avascular, use a vascularized graft. You can use a compression screw or a caver depending on the size of the fragment. Review can be done with X-rays. CT can be done if there is a doubt regarding union. Thank you. Hello. Any doubts? Any questions?
Sir.
Hello.
Sir.
Yes. Hello. Sanjeev.
Sir, for a
Hello.
Sir, can you hear me?
No, actually, the voice is coming. Hello.
Sir, can you hear me?
Yeah. Yes.
So for an undisplaced scaphoid fracture with gap in X-ray, it is undisplaced. So how long do we have to wait for union or to continue with conservative management? How long do we have to wait to intervene for an undisplaced fracture with the obvious gap in X-ray?
If there is an obvious gap in X-ray, then there is no point in waiting, especially if the gap is more than 2 mm. So we can go ahead with a percutaneous compression screw. If the gap is more than 2 mm, it's safer to do a bone grafting.
Okay.
Any other questions?
So what are the ideal indications for conservative management? What are situations we can confidently go for go with conservative management in scaphoid fracture?
So there is something called as stable fractures and unstable fractures. If it's a stable scaphoid fracture, especially if it's a waist or a tuberosity fractures, and if there is not much comminution and there is not much displacement, we can go for a conservative. But if it's at 6 weeks, it is always better to do a CT to assess the union, not an X-ray, because X-ray because there will be post-immobilization, osteoporosis. You won't be able to like you see with the long bones or large bones. It is very difficult to identify the union in a 6 weeks X-ray with a scaphoid. So it is always better 6 weeks you do a CT, and if there is a union, then you can go ahead with restricted movements and all. But if you feel there is it's not uniting, then you can intervene.
Yeah. Sir, I think nobody is having any other doubts.
Okay. I'm sorry I couldn't prepare those two.
Sir, one more thing, sir.
Sanjeev.
So you told that in 6 weeks, if you have a doubt on displacement, we have to take a CT.
Yes.
Sir, but if we do an MRI, we can assess the vascularity also on the same imaging.
No, if it is a proximal pole, of course you can go for an MRI. What I'm trying to tell you is if it's a tuberosity or if it's a waist fracture, most often it will be a waist fracture. And if you have 6 weeks, it is always better to go for a CT to assess the union, because you'll be wasting if you think it's uniting, and if you keep immobilized for another 6 weeks, then at the end of 3 months, if you feel it's not uniting, so it's almost like wasting a time. So when you have better imaging modalities available, which are not very costly also. Is there any other doubts?
So if you are going with operative management, when can we start?
When can we start? Sorry.
Mobilizing the hand after operative management.
Depends. If it's a percutaneous screw fixation alone, then you can mobilize after 3 to 4 weeks. If you are doing a percutaneous actually fixation, and if it is acute fractures, we can actually mobilize quite early, like depending on the pain for the patient, even 1 week, 2 weeks, we can actually start mobilizing. And if it's a bone graft, we wait for 6 weeks. If it is a non-vascularized bone graft, we wait for almost 2.5 to 3 months to mobilize.
So though we couldn't go on with the OSCE session today, hope everyone had a very informative class about scaphoid non-union. Thank you, sir. Thank you for taking the session for us. And thank you all for
Thank you. Thank you. Thank you.
Thank you, sir.
Thank you.